And get started. Welcome, everyone. Thank you so much for being here for our first QTECH committee meeting of 2024. We're very happy to have you here today. We have some great education, great content. We have some incredible speakers for you today, presenters. So we'll go over some housekeeping before we get started. So again, as always, you can go ahead and place any questions that you might have in the chat. We'll be keeping an eye on those throughout the meeting. If you would like to ask a question, just please raise your hand and we'll call on you. As always, the session is recorded, so we'll send out the recording after if there's anyone on your team who is unable to make it today. Again, thank you for participating. Today we have, again, incredible speakers here with us today. So today is a tag team of our clinical quality team, our Healthy Planet and value-based services team, who will be joining forces to bring you the latest and greatest updates around social determinants of health, Prepare, and EPIC's social determinants of health wheel. So we're very excited about that. We're also very happy to welcome Dr. Monica Gomberg from Blue Circle Health. She's going to be going over some of the incredible services and opportunities available to our health centers for their type 1 diabetic patients. And lastly, we'll go through upcoming events that we're excited to share with you all as we kick off the new year. So without further ado, I'll go ahead and hand it over to Karen Iverson, my QTECH co-pilot.
Great. Thank you so much, Natalie. And good afternoon, everyone. Hope everyone is warm where you are. It's chilly up here in the Midwest. I'm Karen Iverson, Practice Transformation Manager here at Health Choice Network. And we are so excited to introduce Social Determinants of Health Part 1. Our possibilities are really both epic and endless. So absolutely roll your eyes every time I make an epic joke. But we are going to talk about SDOH today with an epic lens. So we'll go ahead and go to the next slide. I appreciate the LOLs coming through. We want to make it a little fun for you. So objectives for this particular hour during our QTECH meeting. By the end of this session about SDOH, we want you to be able to do a few things. And these 5 are listed. Define and understand the importance of SDOH. Identify those UDS questions and HEDIS measures that relate to them. Understand the purpose of the Prepare form. Locate and utilize that form, and we will demonstrate it with our Healthy Planet team. And then know the reporting dashboard location as it relates to these social determinant of health elements. So these are the 5 things that we want you to be able to do after our session today. So if we go to the next slide, I'm actually going to stick in the chat. It's just a couple of really quick pre-assessment questions. So let me go ahead and put this in the chat. We can have more than one answer from each health center. I'm going to be quiet for just a moment and let you fill this out. We want to see where you are in those objectives today, and then we want to take a little post-assessment. Be quiet for just a moment. Please let me know if there's any issues getting through this form. Great, I'm seeing some responses come in. Wonderful, thanks all. Give it maybe just another 30 seconds or so. Still seeing one or two come in. Wonderful. Thank you all so much. We'll go ahead and go to the next slide, Natalie. Thank you for filling that out. And I see a couple others coming in, which is great too, but it'll be really helpful for us to see where we can further assist and what we might need to review again. So social determinants of health are the non-medical factors that influence our health outcomes. They are those various conditions and are a wider set of forces and systems that shape our daily life. There are many studies out there around SDOH that we all know. They are really, regardless of what that particular data from that study is showing, all the studies are showing that they are the dominating factors that influence a person's health. So the National Institute of Health, I just published one sentence about that study. It said that medical care alone was only responsible for 10 to 15%. The others were related to social determinants of health. And I think we've seen a lot of studies about that with similar numbers, which is why it's important we're talking about that today. And as we think about 2030, for Healthy People 2030, we are going to be taking a look at SDOH along with health equity, which we've heard a lot about over the last years, and health literacy. Those are the three priority areas for Healthy People 2030. And please note, in looking at the CDC website, they have all their activities around how to address these health inequities and the root causes, one of which is social determinants of health. So it's really a multifaceted problem we need to face. So if we go to the next slide here, I just want to pass things over to my colleague, Caitlin Haggerty. Hi, Caitlin. Did you want to talk about the UDS appendix?
I would absolutely love to talk about the UDS appendix. It's my favorite topic. Hey, everybody. I'm Caitlin Haggerty, the UDS Program Administrator for Health Choice Network. I'm kind of the resident UDS nerd at HCN. I'm sure you've been in meetings with me or heard me talk about UDS in some form or another. So always happy to guest star in another meeting to talk UDS. Social determinants of health are relevant for UDS. And there's a whole section in the Appendix D asking about your collection of social determinants of health risk factors. And this is important because it relates to a badge that you can receive, a check or badge that you can receive from HRSA if you answer these questions appropriately. So in Appendix D, it asks you, does your health center collect data on individual patient social risk factors outside of the data accountable in the UDS? So this is talking about things other than, sexual orientation, race, other demographic information that you collect during registration. And I think we can all comfortably say yes to this question. So even if you're not asking all of your patients, or if you don't have a standardized workflow, someone in your health center is collecting data, the social determinants of health data, and we're going to help you streamline that a little bit. But we know that that data, that you're getting that data from your patients, and so getting that into the EMR in a reportable way is where we want to help. So the answer to that question should be yes for almost all of you. This next question is where it gets a little bit trickier, and how you're going to see where Epic can help with that, is how many patients were screened for social risk factors using a standardized screener during the year. And so we have tools that we'll show you in a little bit that will help you calculate that number for those of you in Epic. And then for other EMRs, there are ad hoc reports or supported reports that you can run to get that number based on how you're documenting those social risk factors in your EMR. It also asks a question about which standardized screeners we're using. In Epic, we have the Prepare built in, but there's a long list of standardized screeners that you can choose from to implement at your health center, but Prepare is the one that a lot of our health centers like to use. And then the UDS also asks to identify different categories of social risk factors. So getting a little bit more granular with those Prepare answers. And so again, in Epic, we can support answering that question. And then Lastly, a question that I hope none of you have to answer, which is if you do not use a standardized screener to collect information, please indicate why. So there are situations where you may decide to take a couple of questions prepare a couple of questions from another screener and combine them into your own. And so that would be a situation where you could explain to HRSA what your process is for collecting social risk factors. Next slide. Okay, so this is where you can find this information in EPIC. We have a special operational program monitoring tools and reports dashboard just for supplemental reports for EPIC. In the UDS appendices section, there is a report specifically for social determinants of health, and that report will show you all of the patients that have filled out that you have data on for repair, and it also will indicate how many patients with some filtering, you can get to the number of patients that indicated that they do have specific risk factors that are addressed in the UDS, transportation, food insecurity, etc. So this report is super useful, and you can use this when you're monitoring throughout the year as well as for end of year reporting. Next slide. I just want to have a shout out here for qualifying visits for your enabling service providers at your health center. So this screenshot is from the UDS manual. It's the page where it lists out all the enabling services staff members that you may have at your health center. And I want to point out something interesting here, which is that there are some in enabling services. I know in health centers, when you're working in enabling services, you may wear a lot of hats. For one patient, you may be helping them apply for Medicaid, and then the next patient you're hooking them up with a food pantry, and the next patient you're doing diabetes education, etc. And so how you categorize these employees for the UDS is really important, because some of the UDS provider types will be designed to generate UDS qualifying visits, and this is applicable no matter what EMR you're in. And some of these employees, you may categorize them in your EMR as employees who cannot generate qualifying visits for UDS. And a visit in the UDS is conducted by a licensed provider who provides independent judgment with the patient. And so typically in the enabling service space, we see nurses or other certified individuals who are going to be in those categories at the top, who are considered UDS providers. So case managers, social workers, other RNs working in the case management space, health education specialists. So this may be your diabetes educator, your certified diabetes educators. This is the only place in the UDS where an LPN can be classified as a UDS provider who can generate visits as if they're in this education space. So keep an eye on that. You may want to identify if you have community health workers who are not UDS providers, who are really more filling the role of a community education specialist. You may want to play with your UDS configuration so that you're accurately getting credit for those visits while not making sure that your configuration is accurate. So community health workers working in a normal community health worker role would not be considered a UDS provider. And this is all really complicated and very fuzzy. And so I'm going to pause here to see if there are any questions in the chat, or if anybody wants to raise their hand to come off of mute and ask a question about UDS provider types. Final plug for those of you in EPIC is to, if you have updates to your UDS provider types, to please get those to me by tomorrow. Appreciate it. Shameless plug. Yes. Anyway, so I know that this stuff can be a little fuzzy. We are always willing, the UDS support team is always willing to answer questions about where certain staff members should belong on the UDS. We have some resources to help you answer that kind of question. So we're always happy to chat and brainstorm and decide fit the puzzle pieces together to see where your different staff members can go to make sure that their valuable work is counted in the social determinants of health space.
And
Next.
Caitlin, one quick question in from Kara. So with the social determinants of health report, when you are answering the number of patient questions, do you just recommend filtering by measure detail?
Yes, so that report will give you, I believe, at the encounter level. And so there will be patient duplicates in there. So you will have to remove those duplicates for the first question to see how many patients were screened. But then, yeah, so on each topic level, I would filter it out and export that and remove the duplicates for that so that you can get the answer for each one. Yeah, use that filtering tool. And if you need help with it, let me know. We can talk about it in more detail offline. I think that's my last slide, Karen. So I'm going to toss it back to you for a minute.
Hey,
Excellent.
I do have one question. This is
Yeah, go ahead.
Comwell. So I know in the Healthy Planet, Cassie, which committee, which I just got the invite for the next one and noticed it's at the same time as QTECH, which for us that have smaller systems, it's going to be hard to pick and choose which one to go to. So if y'all could think about rescheduling that, but one of the things that she talked about was when the case managers or care coordinators or all of those staff are doing outreach, the difference between a telephone call versus an outreach encounter.
So
and
important.
I think that would be that one slide that she had. I know we have a ton of questions because we've got to re-educate our staff for this year, but I know that's going to affect the numbers in visits. So I don't know if we can bring that back to this meeting to pull, because
Yes.
I think that's something that's going to have to be retaught to all staff.
That's such a good call out. And let me expand on that a little bit. And so when you're in Epic, there's an encounter type called patient outreach that will count as a face-to-face UDS visit if you are a UDS provider. And so it's important to note that if you're calling a patient to maybe address some social determinants of health, to see whether the patient answers, so that if the patient doesn't answer, you create a telephone encounter. If the patient does answer, then you can have that patient outreach encounter face-to-face and document that for UDS purposes. But there is a distinction between that, patient outreach and telephone. Dawn, I'm sorry, I might have misspoke. You can correct me.
Oh, no, you didn't misspeak, but we had a lot of follow-up questions about that very topic following the population health meeting. And there was some clarification in the chat yesterday left over from that meeting explaining that you can continue to use patient outreach encounters when you want them to count for UDS. You can use telephone encounters when you don't want it to count for UDS. And we are working currently on implementing a solution so that if you start a patient outreach encounter and then you're never able to reach the patient afterwards, will allow you to turn it into a telephone encounter retroactively. So we're working on streamlining those workflows to make them a little more intuitive and more in alignment with what UDS is expecting.
That's a great call out, Allison. So thank you so much for bringing that up. And yeah, we will bring that topic back again in our SDOH education series that we're going to be doing for QTECH. All right.
Wonderful. Thanks, Allison. Thanks, Caitlin. And great call out about the simultaneous meetings too. There's just, we want to talk to you. All our teams want to talk to you always. So we'll work on that scheduling. So if we go to the next slide, I'd like to introduce Jillian Javed, who's going to talk about the HEDIS measures that relate to social determinants of health. So I'll pass the floor to Jillian.
Great. Thanks, Karen. Hi, everybody. My name's Jillian Javed. I'm the Director of Clinical Operations for our Value-Based Services division here at HCN. I'm a nurse by background, and I've been with the company for about 7 years and in the network for over a decade now. So it's still scary to say that out loud, but here we are. So we're kind of tying social determinants of health all together, looking for those components that make this such an important topic. I know all of us are kind of hearing this. We're seeing the emails coming from different vendors with the education opportunities. So social determinants is really something that's, although we've been talking about it for many, many years, is really picking up steam in a lot of different areas. So I'm going to talk very briefly today to introduce the HEDIS measure. That's related to social determinants of health. So that is the social needs screening and intervention HEDIS measure that was rolled out for the very first time last year. So in 2023 was its first year in existence, and it has continued into 2024. We are seeing some payers start to include this in some of their programs, into some of their quality incentives. So if you are involved with your VBS and your contracts, you probably are aware of which of your payers is looking at this measure and which ones are not. We do expect this one to pick up speed. Usually when one does it, as the years come, the rest of them jump on board with it. So we do expect this one to grow in the coming years. But essentially this measure is looking at 3 different areas. It's looking to ensure that all of the patients under the contract are screened for food, housing, and transportation insecurities. So 3 different domains of social determinants: food, housing, and transportation, and that if they screen positive, they receive some sort of an intervention within 30 days of that screening. So that is the HEDIS measure. There was mention of Z codes in the chat there. So one of the ways that the plans are looking to identify the patients that screen positive are through those Z codes. And I think it's Z55 through Z65, and there's a lot of them in between with lots of dots and 01s and 02s. But within that range is kind of the Z codes that you would use on your encounters after screening positive a patient for either any of the social determinant areas. But specifically food, housing, and transportation is what NCQA is focusing on right now. And then again, the intervention, there are many different ways of intervening. So there isn't anything specifically spelled out in the materials just yet, but examples would be referrals, education, actually providing services to close that gap, whether that's food or transportation itself. So it's actually a 6 kind of piece measure where you're screening for all 3, and then if positive, intervening for all 3, and then using those codes to document the insecurities that you are finding for your patients. And I think we have upcoming, we'll give a sneak peek at the agenda for upcoming SDOH webinars. And in there, we'll go into a little bit more details about what the Z codes are, the numbers and their descriptions and things like that. So we'll talk a little bit more about this in upcoming sessions.
Excellent. Thank you so much, Jillian. And feel free to please place all questions into the chat. We know this is a lot of information coming at you: UDS, HEDIS, even the foundational definitions of SDOH. And now we're moving to, because in healthcare we live in acronyms, another acronym called PREPARE. So PREPARE stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences, because we can't go without another acronym, right? But there is a screening tool. It is evidence-based and validated, standardized across ICD-10, LOINC, and SNOMED codes. And this tool is available in our EPIC instance. So this is a national standardized patient risk assessment tool. Many of you are using the Prepare form in EPIC already. We wanted to bring this introduction to you for those that are interested in using it or seeing another demo. And in alignment with what Jillian was mentioning, the question domains for Prepare are around personal characteristics, family and home, money and resources, and social and emotional health. So with that, I'll go to the next slide and want to introduce Dawn Bell of our Healthy Planet team, who's going to talk to us about Prepare. Hi, Dawn.
Hi, thank you. Hi, I'm Dawn Bell. I am an analyst on the Healthy Planet team. I've been with HCN for almost a year and a half now, but I have about 8 years of experience with Epic Build in the ambulatory and Healthy Planet space. And I am spending a lot of effort lately on social determinants of health tools in Epic, and I'm excited to show you what we have currently. So if we could switch to the next slide, please. What we're going to start with is the visual representation of what we see in EPIC for patients who have been screened for social determinants. They most often present in a wheel shape like this. Sometimes it can be a grid depending on where you are in the system. The functionality is really the same regardless of the display, but we often refer to this as our SDOH wheel, where each segment of the wheel represents a different domain of social determinants of health. Each slice in the wheel is represented by an icon for quick visual identification. So you'll see, for example, a car for transportation needs, a fork and knife for food insecurity, some dollars for financial insecurity. Not all of the icons, in my opinion, are completely intuitive, so you don't luckily have to remember what they all mean, but if you hover over any of the domains, it tells you exactly what it's for. It tells you how the patient last screened, how they screened on their last assessment, when that assessment was done, and the specific questions that were answered that led to that risk score. So in the example on the screen here, we see that the patient screened positive for transportation needs back in February of 2023. And in that case, it was based on the 2 questions in the prepare, where the patient indicated they had difficulty getting to non-medical meetings and appointments, as well as medical appointments due to lack of transportation. The color coding in the wheel is based on severity. So all of those red domains that you see in this example are highest risk. The patient screened positive for risk in those areas. Yellow indicates some amount of risk, moderate risk, and green indicates that the patient is not at risk in that area. You may also see gray colored domains, so you'll see that in the demo in a few moments, and that means the domain has never been assessed. We have no data from the patient in that area. You'll also notice one domain, the one right under the transportation domain in this screenshot, that is green currently, so no risk, but there's a red exclamation point with an arrow. I guess that's what that icon looks like to me. That indicates that the patient may not be showing any risk today, but did at some point in the past screen positive. And so it's an indicator that that domain may be one that you want to reassess more frequently for that patient and make sure their needs are still met. Or just check in and maybe keep a closer eye on that domain. In this particular view, all of the domains have been assessed for this patient. There is no systematic requirement to assess every domain for every patient. We do have tools available to assess every domain, but your center may prioritize specific areas of risk that you will, focus on meeting patients' needs in, similar to when Jillian just presented about the HEDIS measure. That measure is focusing on food, finances, and which other one, Jillian? I'm blanking. Just 3 domains.
Food,
So
housing, and transportation.
food, housing, and transportation. Got it. Thank you. So, you may pick and choose, but if you complete all of the domains, you would see a view that looks something like this. The domains also are customized for certain special populations. So in the example that we're looking at here, I can tell that this patient is either pregnant or postpartum because of there's a domain just to the left of the raining cloud icon. Looks like a parent and child with another raining cloud. That only appears for patients who are currently pregnant or postpartum. So I can tell that I'm looking at an adult who is pregnant or postpartum. There are separate domains configured for infants, children, and adolescents. And some of those domains are aimed at the caregiver. So caregiver health is one example of a social determinant domain for those special PD populations. Some of the domains are geared more at the patients themselves. So adolescent substance use is one example, or child education. And so those domains are special and only appear for those special populations. I think we can go to the next slide. This is good. Okay, so we saw the visual representation of how the data output looks. The data gets into the wheel in a variety of ways. So as we mentioned previously, the Prepare is currently HCN's preferred screening tool. And we have linked the Prepare to the social determinants of health wheel so that when you complete the Prepare, it automatically fills in the matching domains. The Prepare does not cover every domain in that wheel though. So this grid is intended to show which domains are covered by the Prepare, and when they are not covered by the Prepare, what the alternate screener is that we've configured to feed into the wheel. So in the first column, you'll see a list of domains from the wheel. The second column shows if there are screening questions in the Prepare that cover that domain. And if there are no questions in the Prepare, then the third column indicates what the alternate screener is. So as an example, alcohol use is not part of the Prepare questions, but we have the Audit C. That's our screening tool that we've configured for that domain. Similar with depression, there are no Prepare questions that cover depression, but we've made the PHQ-9 as well as the PHQ-A for adolescents available for depression screening. But we see that financial resource strain, food insecurity, and intimate partner violence, the next three domains in line, are all covered by the Prepare. So the expected workflow or recommended workflow in this case to be most efficient, I would say, with completing these screenings at this time is to do the Prepare first. And there are several places that the Prepare can be accessed. But to do the Prepare first, allow that to fill in the risk scoring for the domains that are covered. And then if you would like to assess additional domains or do assess additional domains like depression, for example, as part of your typical office workflows, those can be done separately. So on the next slide, we'll see some of the places that the Prepare can be accessed easily, and it's different places in the system based on different workflows. So for providers and clinical support staff, the most common place to access the Prepare is on the Screenings tab for a scheduled visit. Care coordinators, outreach workers, anyone who's performing patient outreach encounters could find it most easily on the Assessments tab in a patient outreach encounter. And I do want to call out that patients who are on my chart can actually complete the Prepare themselves. They can receive a patient questionnaire version of the Prepare before their visit and complete it that way through the portal. If they do that, the questions flow straight into the wheel, the same as if clinical support staff or care coordinator or anyone else had entered those responses in the system on the patient's behalf.
Do you have to attach it and send it to the patient, or is that automatically something they can, like we can send it out to everybody?
I don't know for sure what the current configuration is. It can be configured to go out on a regular schedule. I don't know if it is configured that way. I will make a note to follow up and find out how the MyChart team has that configured currently. But as we put more and more emphasis on collecting this data and intervening and providing resources to patients, I think that it's probably something that we could prioritize and, make sure that patients are receiving it regularly without having to manually send.
Thank you so much, Dawn. And other question in the chat as well. If we click on the compass rose, does that data flow into Prepare?
That is an excellent question. So I think if we go back a slide, let me just make sure I understand. One more slide, sorry. Is this question about clicking the heading that says social determinants that opens up a form with a bunch of questions?
It is.
Okay, so we get a lot of questions about this, and I appreciate it coming up here. The Prepare has been embedded in several workflows, as we just saw, to kind of meet you where you're already doing your work. If you're already rooming patients, we put it in the place where you're rooming patients. If you're performing patient outreach, we put it there. There are additional questions that are available under the social determinants of health header that are not the Prepare. They're different screeners. And we've left them there for various reasons. It gives us flexibility to expand the wheel to use those additional screeners. So 2 use cases we have so far. One is that one of our centers had a special requirement to meet grant requirements to perform the hunger vital sign screening. It's a 2-question screener for food insecurity. It's different than the prepare, and it's available under the social determinants of health header there by default. So it was already available, just not linked to the wheel. And so we were able to leave it right where it was, link it to the wheel. So now both the prepare and the hunger vital sign can be used to populate the wheel. Similarly, we just had a recent request for the HARC intimate partner violence screener. That is also available under the header, and it's different from the prepare. And so we'll be implementing that very shortly, probably next week, so that both the HARC or the prepare can be used to document risk for intimate partner violence. So they are not the same, and it's intentional that we're leaving them that way for now so that we can utilize those additional screeners that come with Epic. They're already there. They might just need to be linked to the wheel as we have use cases for them.
Wonderful, Dawn. And in the case where the questions are the same, do the answers to those questions drop into the same place for reporting purposes?
Let's see. I'm not sure I understand the question. Or the questions are the same. Could you clarify, Daniel?
Sure. If I'm accessing the SDOH questionnaire through the wheel,
Mhm.
and I enter answers on the thing that comes up,
Mhm.
if I then switch to the prepare assessment, will the answers that I enter on the wheel be present on that assessment?
I see. If you go through the header, if you click the social determinants of health header, I'll demo this in a minute, especially for those who aren't on Epic, it's probably difficult to envision what we're talking about right now. The form that opens when we click the header is a different set of screeners. The individual domains on the wheel are linked to the individual screeners that may be a piece of the prepare. So if you use an individual domain link, for example, in this screenshot, if we were to click the transportation needs hyperlink in that hover bubble, that will open up the piece of the prepare that addresses transportation needs, and it will appear in the prepare the same as if you had started with the prepare and let it flow in that way. So that will go either way. But the screeners under the header are not the prepare, they're a different set of screeners.
Thanks, Dawn. I know you're going to demo this too, so you might want to
Mhm.
let me know if you want to show this in the demo. Another question, are interventions tracked to the specific need? Example, food insecurity linked with food resource intervention.
Yes, I will show what that looks like. I think we're going to delve more into interventions in a future presentation, but I can show a little bit about what the intervention workflow can look like with this screening workflow.
Great, thanks, Dawn.
Sure. I think this is a good time to jump into the demo portion. Dawn will now demo. There it is. Okay. I'll steal the screen.
Perfect timing.
Can you see my screen okay?
We can see it.
Okay, perfect. So I am logged into Epic as a care coordinator. I am viewing the schedule for tomorrow, and I see that I have a patient coming in tomorrow who has no social determinants of health screening data entered yet. And I can tell that because I've added the column to my schedule view that tells me the last date of the prepare completion. That column is blank, but I could also tell by clicking
Oh, Dawn, I think you might have frozen just for a moment. Dawn, can you see us? If Dawn can hear us, what I'm going to have her do is remove her camera view, I think that will help too. I'll give it just another minute to see. All right, I think Dawn hopped off, and I think she might hop back on. We definitely want to cover the demo, so I want us to walk through that piece of it. But if you don't mind, Natalie, just while we wait for Dawn, keep looking for Dawn, and I will share my screen because we can talk about, for the moment, but let me know when Dawn's back on, about the reporting features. So being mindful of the time here, where can we find how we are doing with screening around social determinants of health? So there is a dashboard that's available. It is a mouthful. It's called HCN UDS Operational Program Monitoring Tools and Reports. But look for HCN UDS Operational Program. When you go into dashboards and you go down to the bottom appendix area, Appendix D, as Caitlin was showing us at the beginning, is showing social determinants of health. You can pull this dashboard and you can identify what are those complex or simple social determinants of health questions that are being asked, and what is the value, what was the patient's response to that data. So I want to take a pause here. Natalie, do you see Dawn back on?
I don't think she's been able to rejoin.
Okay, we'll go to the next screen. We went ahead and pulled the data from the UDS operational dashboard and took a look at our 20 community health centers that are live on Epic. And of the 20, I do see 13 health centers that we can see data responses for from patients regarding social determinants of health. So what I'd like everybody to do is go to your dashboard and run this report to see if you see data. If you don't, you may be one of those 7 that we can work with you on getting those responses in the system. So to know if you even have data or not, we want you to run this dashboard down at the bottom. We did see when we ran the dashboard that the financial insecurity questions are the most frequently asked, followed by transportation and then housing. So we saw a lot of answers regarding finance, then transportation, then housing. As we continue this webinar series, there will be a series that we want to cover. We really want to see both the volume of the responses and growing, as well as the number of health centers that are using Prepare. We know there's a lot to do when a patient comes on site, so we're hopeful that our demonstrations and education can help us think through how we can use this assessment. Okay, quick pause, Natalie. Did we get Dawn back? And if we didn't, that's okay.
No, I don't think she's been able to rejoin.
Okay, no problem. Let me go ahead and keep going, everybody. That we wanted to leave you all in bated suspense, which is really what happened. But we will be showing the demo of Prepare. We have a lot more information around social determinants of health to show as well. So I want to move forward with this. There are some operational reports in the reporting workbench that can help you follow up with patients and their social determinant of health needs. So when you go to the reports and then go to your library, you will see 3 different Prepare reports. prepare about a certain risk factor that you wanted to take a look at, patients that are unable to get food, and then patients with one or more social determinant of health risks. So this is another area that may not be related to UDS, but a report that you can use for prepare. And then we've even included, thank you to Dawn, a sample output of what that looks like. So you'll be able to see that risk score, the different factors that have been assessed, and then you can run it by time frame as well. So another helpful tip here to ensure that we're utilizing the prepare form to evaluate our social determinants of health. Okay, I want to talk about what's next in just a moment, but I know that we're skipping just a bit because we're trying to get Dawn back, but I don't think she's able to join. But one thing I wanted to share with you, let me confirm that you can see my screen. I'm playing a little hop and a skip on this. Can you see the program guide, Natalie?
Yes.
Okay, great. We wanted to let you know that the Healthy Planet team has developed a program guide all about social determinants of health. So the domains that Dawn was referring to are in this guide, as well as some really critical information. We want to show you where this is located. So this is actually, even if you go in Epic and click F1 for learning fun, you can also type in SDOH reference guide, and that guide will be there. So we want to make sure that you have reference to it. And I know that when we come back together and review the prepare demo with Dawn, we will get a time for that. Dawn will also talk about use of the program guide. So I want to take a pause there. I know Dawn's not here, but there might be questions we can answer. Any additional questions at this time that we can see? Let's see. I see CareArc has data. I love it, Amanda. Daniel, Providence Community Health Centers has data. That's great. And then Allison, great information. Everyone will need to change the date range to the entire calendar year. Very good point when you run that dashboard. I think Amanda has a question. Hey, Amanda.
No, I was just going to say my numbers look a whole heck of a lot better when I changed the dates. I was very, very concerned
Hey.
with what the information I had, because I thought it was pulling the full year, and I'm like, oh my goodness, we have not been doing this. And then I pulled the rest of the data, and we have been.
Me too.
Wonderful. Well, tell us a little more. What did you first pull? What was the date that you first pulled?
I think it only pulled a 2-week time period or something like that.
Okay. Yep. Maybe we put it on
So,
there to scare you at first, just to see. Wait, do we have data?
Maybe. I just was looking at that and I'm like, we just talked about this.
No, this is wonderful.
We're not doing great, but we're doing a whole lot better than I thought we were doing.
Yeah, this is great. Amanda, can I ask you, just because we have a minute, can you talk to us about what CareArc is doing around social determinants of health? What have you been working with your staff on in terms of training and education around this?
Well, right now we're just working on making sure that it gets into the workflow. I know when we trained nurses at the very beginning of starting, we told them that that was a necessity with every patient. And, you know, for some reason, it's at the very end of the rooming. And so a lot of times it gets dropped off. So we've been trying to reinstill the fact that they need to get that information. And we've been talking to them about why, because if you see on the wheel there that a patient has gone without their medication because they can't afford it, the provider can use that information and say, okay, we're not going to prescribe you this expensive medication. We're going to start with these things and see what we can do to add other medications so that we can keep you from having to pay for this other prescription. If they have problems with transportation, it's ensuring that we're calling the patient early enough when they have an appointment and saying, hey, I know that you have problems with transportation. Remember that our LCAT, which is our Lyon County Area Transportation, that it's a free ride and you can call and arrange for transportation if the times don't work for you, or make sure that they know what the best times are so that they can catch the bus and get here. So there's a lot of different ways that we can use that information for patients. We just have to get in the habit of collecting that information. And so we just had another nurse meeting this last week that we talked about SDOH and talking about making sure that we're collecting that information. The other thing we noticed is we have kiosks that are at the front of our clinic. When patients check in on there, the front desk is saying they're taking too long at that kiosk. And I said, well, you have to remember, if they're checking in on the kiosk, they're doing the social determinants of health, they're doing the depression screenings. I said, it's either going to get it there at the beginning of the visit, or they're going to get it back when they go to the provider and nurse. So I had to kind of make that, we're okay with them checking in on the kiosk because it automatically feeds them that information versus the nurse having to remember to pull that screening tool up.
Amazing, Amanda, just wonderful. I do see that Dawn is back. I think Dawn is back. Hi, Dawn.
I am. I apologize. I think my Teams crashed and I have no idea when you lost me.
It was just at the very beginning. And I
Oh,
think what we'll do, everyone, is I'm looking at the time. Dawn, can you prepare, but this is a challenge now. Can you do it in under 10 minutes and then we can do a part
yes.
2? Okay,
Yes, I
that sounds great.
apologize. I will need to get back into Epic. I had to reboot everything to get it all to show back up. So it'll take me a moment to get logged back in, and then I'm happy to do a 10-minute SDOH demo.
I love it. And maybe what we can do as well while you're logging back into Epic is, thank you, Natalie, for the screen. We are, first, great feedback, Amanda. I mean, I'm already thinking about maybe Amanda could present on a future SDOH. I won't give you any work to do. We'll have a conversation about it. But so what's next, though? To use a term from Jillian, we want to screen, we want to intervene, and we want to code. So we want to have information and education around these areas. In the screening, so we want to talk about CHC workflow roles, use of MyChart. You guys had some great questions around MyChart. We want to talk about the program guide. And Dawn, I think we'll save the program guide for part 2. And then future reporting. You all have gotten into the dashboard, which is great, and started looking at that. We want to talk about intervening. So leveraging those relationships and looking at the community resource directory in Epic. And then also coding. So I know Legacy had a great question around Z codes. So Z codes and future tools will be available. If there's other topics around SDOH, it's a large initiative. It crosses different entities, different accreditation organizations like NCQA, like Joint Commission. Let us know what other topics we can cover for you that you'd like to see. And I wanted to, let's see, any requests for future reporting to have 1 row per patient? You know what? We are taking requests. 1 row per patient, right? All right, we'll note that. So Dawn, do you have Epic
Yes,
open? Are you ready?
I do. Yes, and I apologize. I went through my whole demo not realizing that I had disconnected. So you will see some data filled in here that I did from scratch during my demo that you missed. So I'm going to
No
stay off
problem.
video. Hopefully that'll help. My apologies. So I am logged in as a care coordinator in a test environment. And looking at the schedule for tomorrow, I have a patient who had no social determinants of health data. So when I first came in, when I was previously demoing for you and you couldn't see, all of the domains in this wheel were gray because the patient had never been assessed. So I launched a patient outreach encounter in order to complete the prepare. And as a care coordinator, in my workflows, the easiest way to access the prepare is through a patient outreach encounter on the assessments tab. So that is where I went. And you can see, actually, if we close this up, you'll be able to see them better. You can see the previous responses that I put in when I was demoing to myself. So based on the responses that were entered, that populated the wheel. I talked a little bit about the difference between the prepare linked domains and the non-prepare linked domains. The ones that were documented through the prepare, if I hover over any one of them and click the hyperlink for that individual domain, that will pop up just the prepare questions that are linked to that domain. So for centers that are completing just portions of the prepare, which we've heard is a common workflow for some centers, that would be the way that you could do that. You can click just the one domain from the prepare that you want to assess. It'll pop up the prepare questions, and you don't necessarily have to go through the whole assessment. For the non-prepare linked domains, like depression, for example, clicking the link will open up the appropriate linked assessment for that domain. So the PHQ, the smoking history, the audit C, and so forth. Those are the individual pop-ups that will appear if you click those individual domains. If you click the header, this is what we were talking about a little earlier. The header will open a set of screeners. You can see the references here on some of them for where they come from. These are not the prepare, and we're not expecting them to be the prepare. This gives us flexibility to use some of these additional validated tools that are available in Epic that are separate from the prepare. So the prepare, we've looked at different ways you can get to the prepare. You can get to it through patient outreach. You can get to it through a scheduled encounter. Patients can fill it out. You can click the individual prepare linked domains in the wheel. Those are all ways that you can access the prepare information. But clicking the header for the social determinants of health wheel gives access to some of those other validated tools that are separate from the prepare. We had a question earlier about interventions, referring community resources. So built into the wheel here, for any domains where the patient assessed to have some risk, if we click the link underneath the wheel that says Find Community Resources, there is a directory, a repository of local community resources that some centers have submitted to have imported into our system. Not all centers have. If you would like to do that, you can certainly submit a request to my team and we can send you a template that collects the information we need to get those into the system for you. But it filters automatically based on services that support the domains where the patient was at risk. So we're not seeing every domain here right now. We're just seeing the ones that my test patient tested positive for or screened positive for. So if I click one of these, if there are any resources near the patient's address, or near, in this case, it's my address because my test patient has no documented home address. So this is the address of the department I'm logged into. You would see those appear here. Since there are no resources configured that are local to this particular address, I'm going to just remove the address so you can see an example of some resources that are configured in the system. We have quite a lot of Florida resources, quite a lot of Texas resources. We have Hawaii resources in the system now. So we do have quite a list of resources, but they may not be local to your center if you have not submitted your own list. But by selecting a resource from this list, This will flow onto the after visit summary for a scheduled visit. It can be sent through text or email to the patient manually, and it can also be sent through my chart message. So there are several ways to get those resources out to patients. And I think we'll go into more depth on those on a future presentation, actually. Other
Dawn.
questions? Yes.
Wonderful. Thank you so much. We do have some questions, but I would love for you, if you don't mind, to take a look at them and maybe answer them in the chat,
Yeah, of
because
course.
I'd love to move ahead with the Blue Circle Health team and Crystal and
Absolutely.
Natalie, who are going to give that information. And Dawn, I want to thank you so very much for hopping back on in the middle
Sorry
of
for the
that.
technical difficulties. Thanks for your patience.
That's all right. Everyone, thanks for hanging in there. We will answer those questions in the chat. And then I will go ahead and introduce Natalie and Crystal for the Blue Circle Health team.
Thank you, Karen, and thank you, John and Jillian and Caitlin for being with us here today. So up next, we are very happy to welcome Dr. Monica Gomberg. She is the Vice President of Clinical Care and an endocrinologist with Blue Circle Health. She's going to be speaking to us today about services available for your type 1 diabetic patients. So Dr. Gomberg, welcome. I hand the floor over to you.
Thank you so much, and thanks for allowing me to be here. And it's been a very interesting talk so far, so I've appreciated all this opportunity to listen as well. But I'm here with Blue Circle Health, so just so you're aware, we are a free education, care, and support organization for people who live with type 1 diabetes, and we're all virtual care as well. Next slide, please. So just for some background, people who live with type 1 diabetes in our under-resourced communities experience all these negative outcomes, unfortunately, specifically related to their significant cost of care, over $18,000 a year, leading to higher A1Cs, a significant increase in ER visits, fewer physician office visits, a higher mortality rate versus those with a higher socioeconomic status. And then 25% of these patients are med reducing or delaying their medicine, meaning skipping their insulin or making it last longer by giving lower doses, thus winding up in DKA and increasing their hospitalization. And it's a vicious cycle for these patients. So because of this, we thought, well, what can we do and what can we do better for these patients? And that's why we're here. Next slide, please. We are philanthropically funded by the Helmsley Charitable Trust. We're very, very fortunate to say that. And we are here to be the healthcare system that should exist for these patients. Next slide, please. So who we are and what we do, we are a remote type 1 diabetes program, and we're designed to offer these clinical education and support services over typically a period of about 3 to 6 months. And we identify patients' goals and we work to meet those goals. And I'll explain a little more about that. And after reaching those goals, the patients can remain connected to Blue Circle Health, and they can remain connected to the community that we create here and that they are a part of here. And they can re-enroll as needed. But just so you're aware of what's involved in us, we have type 1 diabetes related clinical care. So that includes myself as the endocrinologist. It includes Eleni Sheehan, a nurse practitioner who also lives with type 1 diabetes. We also have an educator, a CDCES, and RD, who also lives with type 1 diabetes and has been working specifically in the T1D realm for many years. We have two insurance navigators who work to help connect patients to getting insurance. A lot of our patients are uninsured and undocumented, as well as providing them with what their benefits are on the insurance that they do have and understanding what related specifically to diabetes is included in their plan and what might not be. We have an amazing LCSW. She does case management as well as diabetes support counseling related to the distress surrounding diabetes that all of our patients live with and suffer through, and can have these counseling sessions with them. And then we have peer coaches. Our peer coaches live in the communities that our patients come from, and they walk the walk by having type 1 diabetes and share life experience related to life's ups and downs, having type 1 diabetes and just getting through regular day-to-day life. So that's who we are. We all come together. We create an individual care plan for the patient that includes one or all of these services, as much or as little as the patient might need, in order to serve their needs. And specifically, if you're referring a patient to us, you might refer and say, we have amazing educators at our center. You don't need that. We have an endocrinologist. We don't need that. But this patient does need case management or does need supportive counseling related to that. And so we can be kind of customizable to what you want from us and what your patient needs from us. Next slide, please. The patient journey. So the patient can contact us. You can refer the patient. We can reach out to the patient. However they get to us, we will talk to them and determine their eligibility. We have some eligibility criteria that I'll talk through, and we'll enroll them when they're eligible. If they're not eligible, we'll give them some resources to connect to, because while we wish we can help everyone, we can't. And so we'll give them vetted resources that we can connect them to. Once they're enrolled in our program and they're eligible, we'll identify their goals related to their type 1 diabetes care, develop that care plan that I talked about, and then begin delivering the services. And we're seeing patients as frequently as they need us to during that time frame in order to meet those goals. Once those goals are achieved, then we hope that they can stay connected to us in whatever way they need. And so this is their journey and what to expect from their time at Blue Circle. Next slide, please. And so the eligibility that I talked about, and this is as of this month, so they must have a diagnosis of type 1 diabetes, and they must be 18 and up. So adult patients, we are hitting that vulnerable time range of that 18 to 26, but adult patients. English and or Spanish speaking. The reason we have that is because we have teammates who speak English and who speak Spanish fluently. And so we're able to provide them care in specific service lines in their language, in their language of choice. We do have interpretation services for those like myself that unfortunately I only speak English, but I'm able to talk to my patients in Spanish through wonderful interpretation services. The patient must be able to connect and willing to connect in virtual care. This does not mean that we're requiring everyone to have a smartphone or a computer. It does mean that they need to have access for it at the time of their appointment, whether it's through a friend or through the library, whatever it is, they must be able to connect to us for their visits. And they must have a PCP or willing to be connected with one. This was really important to us, and especially to me as part of this organization, is keeping the patients in their medical home. We are simply an addition to what they have, and to be able to support you all in your patient's journey, and never ever this replacement. And so we are emphasizing the fact that this patient must continue with their care and must communicate with us about that. Right now, we're in Florida. We're already planning expansion this year, and we'll certainly let you know for your colleagues in other locations where we plan to expand. And if you have a specific location, state colleague in mind that is really interested in having Blue Circle in their state, please reach out to us and we'll work to see where we can prioritize that. The only exclusion criteria is no current pregnancy. And the reason for that is we feel that our patients who are pregnant deserve hands-on care and require hands-on care. And we think we would be doing them a disservice by taking on that without giving them what they need. Next slide, please. So what to expect from us. So currently the way that we're providing patients, thank you for the invitation to Texas. Currently the way they're providing patients is giving same day outreach to those who refer a patient. So you send us an email, I'm sending it to my team, we're calling them that day. As we expand and as we get more and more patients, that could change, and we want to acknowledge that. And there can be ebbs and flows with that. We are, growing and expanding as we speak, but we are very proud to say that this is what is going on currently, and we're getting very prompt outreach to our patients. We're also scheduling appointments with them in a week if they want them. So while we get on the phone with them, they have one enrollment call, we identify their needs, and then we're getting them appointments scheduled. We also have standardized regular communication with PCPs. So Crystal with HCN, she joins me every month, and we have 2 meetings for all of our clinic partners where they can come and hear about, case presentations from Blue Circle Health, updates from us, updates from you all, ways that we can stay in communication as to like what you may need and what we're doing and how we're doing it, and getting feedback on that as well. And then we connect patients to local resources. So we work through the Unitas platform. I know you talked about the Prepare screening here, so many of you may know that. And we work to connect patients back into the community. So it's kind of a nice cycle for us to all be working together and refer in, refer out. Next slide, please. I want to talk about two unique programs that we have for our patients that we're really proud of. One is called the Intro to CGM program. That's for anyone who does not currently have a CGM and has not used one in the last several months. During that program, they can receive 2 free Freestyle Libre 2 sensors. So that is 1 month's supply shipped directly to the patient free of charge. We provide education pre, education post, make sure they're actually using it in the best way and they know how to prevent it from falling off. They know how to read their reports. They know how to interpret what might happen now that you have, instead of one finger stick, you now have a ton of data. What does that mean? It can be very overwhelming for people. So we support them through that. And then most importantly, during that time, our team is working to figure out how we can establish sustainable access for these patients and it not be this one and done thing. Although I will say, anyone who has a CGM for any length of time, it does provide a whole lot of information, a lot of really helpful information that cannot be discounted for the fact that that 1 month is actually very helpful in and of itself too. We also have our patient assistance program, and that's for those at or below 300% of the federal poverty level. Anyone who feels that they want to apply can apply, and once approved, well, actually through the process, our insurance navigators can assist with that application. So they're not feeling like they need to do that without support. Once they're accepted, they can receive 3 months of financial support to cover their type 1 diabetes prescriptions. And so for perspective, I'm seeing patients who are approved for our PAP, Patient Assistance Program, and I'm writing 15 prescriptions on average for them for 3 months. And that is literally everything from their insulin and their glucagon to alcohol swabs and glucose tablets and everything in between. And so they're able to take that off the back of their head for 90 days, and they don't have to spend a penny on that, and they can focus on their health and focus on getting plugged back into whatever they need for their medical care. During this time, similar to the intro program, our insurance navigators, our case manager are working with the patients to identify ongoing coverage and how to sustain this and how to empower them from here. Next slide, please. I've said this before, it is worth putting on its own slide. It is worth saying again, we never ever replace your care and the care that the patient gets at their clinics. We are an additional resource. We provide short-term coverage to help them meet their goals. And so we can be a la carte. We can be what you need. We can be what the patients need. And the reason for that is we have no interest in providing services that you're already providing. That allows us to help more people. It allows more people to get in our door, more people to get the help they need. And we're really happy to do that. It also keeps the people in their medical home, these patients who need to have boots on the ground and referring back to everyone there. So we're happy to partner together with you all. Next slide, please. The current state, just for some perspective on us, we have 36 team members. We have 7 services launched. We've had over 3,000 individual patient encounters. That's, individual interactions with patients, 102 individual care plans developed. 49% of our current patients are enrolled in that patient assistance program that I talked about. 38% are enrolled in that intro to CGM. And the reason why that's not higher is some people are coming in with CGMs already. So those are people that don't need that, thankfully. And then we've had 127 Unitas referrals. So referring back in the community back to you all. Next slide, please. I won't read this verbatim, but you can see we work really closely and we're really proud of our relationships that we've had with our partners. I will call out Colleen at Treasure Coast and Dr. Frey at Tampa Family, 2 of our many champions that we work very, very closely with. You can read their report here. I know these slides I think will be available to you. And I think we get really good feedback from them on things that we need to change. We very much value that, as well as things we're doing well and that we can keep doing for you all. Next slide, please. I'll talk about some impact stories here just so you get some really overarching view of what it is we're doing on a daily and weekly basis and what to expect if you send a patient our way. Next slide. So Miguel, he's a 65-year-old individual. He's lived with type 1 for over 35 years, and he joined Blue Circle over 6 months ago. He previously received Medicaid benefits, but unfortunately they were abruptly terminated due to an immigration error, and therefore he was left without any income and without any means for affording his medicine. And of course, as we all know, this is not like an anomaly. This happens. So he came to us, and he was thankfully referred to us from one of your teams, and our Coach Christian, alerted the care team, and we urgently created this individualized care plan for the patient to get the ball rolling for him. 2 insurance navigators were involved in his care and assisted in completing our financial assistance application, gathering the documentation he required, submitting it, and he was actually very quickly approved for this. In the meantime, our LCSW, Catherine, was providing resources and guidance regarding the residency documentation and Medicaid redetermination process. Our educator, Sherry, was providing education, and through her guidance, his time in range was 86% and had remained there in the high 80s and low 90s every time I took a look at it. Eleni, our nurse practitioner, provided CGMs through the Introduction to CGM program, as well as a 3-month supply of everything he needed, thankful to that financial assistance, that PAP program. And then our coach, our CAs, and our entire care team continued to support him. So you can see there was a lot of moving parts all going on at one time, and we were able to streamline that process for him. I'll share one more story with you. This is James. He's in his 40s. He was diagnosed with type 1 diabetes as a really young baby, and he's had multiple comorbidities, including neuropathy, cardiovascular disease, glaucoma, GI complications, all of which work together to unfortunately limit his own independence. He's also been struggling with housing insecurity for many years, and recently faced an imminent risk of homelessness. And in fact, I just saw this individual this morning in follow-up. We perform a diabetes distress scale on everyone that comes through our door, which identifies their areas of distress in multiple different segments. And I just wanted to pull out a few things here. His highest distress, his highest level of scores were on powerlessness and on negative social perceptions. I also want to point out on this slide, one of the things that was not on here was his confidence in his experience with the medical team that he's had so far, his trust in medical authorities, basically. And so he's been very happy with his care. But the numbers that were really high on here, he shared with me personally that it was because he struggles with housing insecurity, struggles with transportation, and so therefore takes many buses to get where he has to go. And in that time frame, he often spends like 3 buses to get to a place that should have otherwise been 20-minute drive. And so it takes him hours. So of course he brings his insulin with him. Of course, he brings his glucometer with him, and those are needles. And therefore, he brings the needles out to give his appropriate medication and check his blood sugar. And the cops have been called 3 times on him in his life because everyone judged him for doing drugs on the bus, for shooting up heroin on the bus, because they don't understand that this is insulin. And this was an individual who faces judgment on an everyday basis. And social determinants of health has caused this in his life, and it is very unfortunate. And so this was a significant thing that kept recurring and that kept being a real big problem for him. And so he brought that to us, and I'll talk to a little bit as to what we were doing to hopefully make that a little bit better for him. So Catherine spent countless hours on securing affordable housing, emergency shelters, urgent financial assistance, and other critical resources. He currently has a housing voucher, and when I talked to him this morning, he told me that he was just waiting for them to be cleaning up the house from the previous tenant, and that he should be moving in shortly. So her hours of work really did pay off for him, and he did a good portion of it along with her. And so our goal is to empower these patients to not need us when they don't have us, for example, and he really put in a lot of time and effort. We also, the educator, Sherry, and myself, we've been doing insulin adjustments, setting individual goals, and following up with him pretty much weekly because he had a lot of other things going on. He was unable to really focus on his own medical needs. And even with that, his time in range improved from 23% to 32% in 2 weeks. I will say I saw him this morning and he was up to 38 or 39%, which I was so proud of him. And he was so proud of that. because he's been struggling in the 20s for so long. And to have that improvement when you don't even know where you'll live for the night is really impressive to me. Xanadu, our coach, has been providing ongoing support and empathy. Our CAs have been ensuring his communications and appointments go smoothly for him. And then our insurance navigators have helped him understand his Medicare and Medicaid insurance benefits and enrolled him in the financial assistance program. I do want to point out one of the things that Intro to CGM program that we did for him has been paramount for him in making him feel comfortable getting on the bus again, making him feel like that is one less needle that he has to bring out in public, one less judgment that he has to have on him. And it has been life-changing for him in so many ways. Thank you for letting me share his story. I put a few more quotes on here as to what our patients are saying. We're getting good feedback. We're getting good experiences on their end. And most importantly, if we're not, we want to know. And like I said, we're always open to taking feedback on that. Next slide, please. So how we can partner. So as I mentioned earlier, we have our FQHC and clinic standing monthly meetings. We do 2 meetings a month that are identical. So one is in the morning, one is at a lunch hour, in hopes that some of your team can attend one, some can attend the other. We can report back to one another and get some feedback on that. And we do case presentation one month, alternating with updates the following month. So hopefully make it productive for everybody. I can also do provider meetings if at any point your clinic would like me to speak to your providers as to what we do. I know, many people are not on this call because people are all different areas. If their providers are in one certain meeting, I'm happy to talk to them and see how we can help. We can also have one-on-ones at any time with myself or anyone on my team. You can send referrals. You can email referrals to referrals@bluecirclehealth.org. You can also enroll online. We're really happy to say on our website, bluecirclehealth.org. You can go and click enroll now, and you can plug in, your patient can plug in their own criteria directly, and we can determine if they're eligible for enrollment. You can also have your patients call us. Here's our 800 number right here. And then for general information and updates, you can feel free to sign up for our newsletter. It's on our website, or if you have general questions, email us at info@bluecirclehealth.org. Our newsletter gives you updates as to what we're doing and where we're going. And I'm so glad I just saw that pop up. If I did not emphasize that, I do want to. Thank you for Crystal for answering that. We're absolutely free for patients, and none of our services are charged to them. The only charge that they might get in their time with us is through their pharmacy, which is out of our control. If they have to pick up a prescription through their insurance, I wish we can control that. We can't, but everything is no cost to them. Every meeting that we have, every service we provide, no cost to the patient at any point. And we see, as I mentioned, we see insured, uninsured, undocumented, across the spectrum. We treat everybody the same. The only qualifications are through our eligibility criteria, which we can send out. It's on one of the earlier slides here. Next slide, please. Actually, that's the last slide. My information is here. Please feel free to email me directly. I don't know how much time we have. I'm happy to take questions, or if I missed any, I've tried to catch a few coming through the chat, but I'm sorry if I missed them.
Thank you, Dr. Gomberg. We'll open it up for a few minutes if anyone has any questions. Otherwise, we can place them in the chat, or you have Dr. Gomberg's contact info here as well.
And maybe, Natalie, could we go back to the eligibility criteria slide? There is a question about we could just review how patients qualify for the program.
Yes. Thank you. I was just going to recommend that too. I appreciate you saying that. Yes. So here's our eligibility criteria. Type 1 diabetes, adults, English or Spanish speaking, must be able to connect to virtual care, and doesn't mean they have to own a phone, but connect with us when they need to. They must have a PCP or are willing for us to help connect them to a PCP. They must reside in Florida, though we're planning expansion, and the only exclusion of criteria is active pregnancy at this time.
Perfect. Well, thank you so much, Dr. Gomberg. Thank you for stopping in and for leaving us with this information. And as Dr. Gomberg mentioned, we also have Crystal Walker, who is our diabetes program administrator. She's here on the call as well, and you can feel free to email her. She put her email in the chat as well for anyone who wants any additional information on Blue Circle Health. So thank you so much. Thank you. Alrighty, so we'll go ahead and close out the meeting. It's we have a few upcoming activities that we want to share with you all. So first and foremost, we have our upcoming American Heart Association Heart Walk on Sunday, March 10th. If you'd like to join the walk, or if you cannot attend and you'd like to donate, you have your QR codes there. We'll be sending out the slides as well, so you can take your time to decide if you'd like to join us at the walk. We also have our first ever pharmacy symposium taking place on March 13th, and we will have a networking dinner on March 12th. So again, if you're interested, please feel free to scan to register. It will be at the Health Choice Network offices, and there is a virtual option available as well. And we are also happy to announce our upcoming board educational conference. This is our big 30th anniversary board educational conference. So we urge you to add those to your calendars. Registration will be open soon. As soon as that is available, we'll go ahead and share that with the group. And also, we've reached out to a few of you, a few health centers regarding our QTECH questionnaire. So the names here, if you could take a moment, it should take a few minutes to complete. This will help us gauge our education and resources that we'll be providing throughout the rest of the year. So if you could take a moment to complete those, please do. We've extended the deadline to complete. And we also have a post-test, a post-survey that Karen will be sending out shortly relating to social determinants of health, as well as our cybersecurity team. They will be sending out a survey for your team to complete as well, so we can try to put together some resources and hopefully a series on all things cybersecurity related, and see where we can provide you with that education here in this forum. So lastly, we have our upcoming work group. So we have our next quality work group on Tuesday, February 6th. Our next HIV task force meeting is Tuesday, February 13th. And our next QTECH committee meeting will be February 22nd. So we look forward to seeing you all again. If you have any questions, again, please feel free to reach out to myself, Natalie Mesa, or Karen Iverson. And we'll see you all next time. So thank you very much for joining, and have a great rest of your week.
Thanks so much, everybody. And I just
Bye.
stuck that post assessment in. If you could take just a minute, we just want to see where we were and what else we can do to demonstrate in the future. So thank you so much.
Thank you, everyone. And thank you to all our speakers.
Have a great day, everybody. Thanks, Dr. Gumberg.